Welcome to our attendees who have joined us today and to those joining via the recording to the North Simcoe Muskoka Specialized Geriatric Services practice short for December 2025. My name is Allison J. Aware and I'm one of the psychogeriatric resource consultants with NSMSGS. I'd like to begin with a land acknowledgement. We're gathering on traditional lands sacred to many Indigenous nations. I would like to acknowledge the traditional territory of the Anishinaabe, which includes the Odawa, Ojibwe, and Potawatomi nations, collectively known as the Three Fires Confederacy, the Haudenosaunee and Wendat nations, and the presence of other First Nations, Métis and Inuit, residing in Simcoe, Muskoka. Most of us have come here as settlers, immigrants, or newcomers in this generation or generations past. We are all treaty people. As such, we commit to collaborating based on the foundational assumption that Indigenous peoples have the power, strength, and competency to develop culturally specific strategies for their communities. We're dedicated to honoring Indigenous self-determination, history, and culture, and are committed to moving forward in the spirit of reconciliation and respect with all First Nation, Métis, and Inuit people. Today's session is being recorded and will be accessible on the SGS website. If you're watching the recording, welcome, and a reminder that if you'd like to join us live, practice shorts are offered the second Friday of the month at 8:30 in the morning. It gives me great pleasure to introduce today's speaker, Ashton Underwood. Ashton is a registered nurse who graduated from McMaster University in 2009 and embarked on her nursing career as a visiting nurse in the community. Since August 2018, she's been a proud member of the North Simcoe Muskoka Specialized Geriatric Services team, where she's dedicated to supporting the health, dignity, and quality of life of older adults. In 2022, she obtained her gerontological nursing certification with the Canadian Nursing Association. Her passion for senior care continues to grow as she pursues her Continence Nurse Advisor certification and contributes to the development of a regional continence program. Welcome, Ashton.
Good morning, everyone. Thanks so much for joining today. I really appreciate the opportunity to talk to you for the next 20 minutes or so about continence assessment and the older adult. To get us started, I wanted to review some of the specific objectives for today's presentation. So to explain the significance of the continence domain within a geriatric assessment and its impact on older adults' function, dignity, and quality of life. To outline key components of a continence assessment, including history taking, assessment, and relevant screening tools to aid in your practice. To identify common types, causes, and risk factors for urinary and fecal incontinence in older adults, and to provide practical takeaways to support quality geriatric care. While this may be review for many of you, I thought it important to briefly touch on the anatomy of the genitourinary and gastrointestinal systems in order to properly discuss continence assessment. We will look at the anatomy of the genitourinary system, or the GU system, to start. The GU system consists of the urinary and reproductive organs, which are anatomically linked. While the urinary components, the kidneys, ureters, and bladder, are similar between sexes, the reproductive organs and the urethra are distinct, leading to significant physiological and health differences. Both male and female urinary systems include the same core components with the same primary function of filtering blood and producing, storing, and expelling urine. The kidneys are paired organs that filter waste products, excess water, and electrolytes from the blood. The ureters are tubes that carry urine from the kidneys to the bladder. And the bladder is a hollow, muscular, balloon-shaped organ that stores urine. The male GU system has a unique structure because the urinary and reproductive tracts merge at the urethra. In males, the urethra is a long curved tube approximately 20 centimeters in length that passes through the prostate gland and the penis. It serves as a shared pathway for both urine and semen. The prostate gland is located below the bladder and is a walnut-sized gland that secretes fluid that nourishes and protects sperm. The urethra runs directly through the prostate. The female GU system has separate openings for the urinary and reproductive systems. The female urethra is short and straight, measuring about 4 centimeters in length, and is exclusively for the passage of urine. So now that we're refreshed on the anatomy and function of the GU system, I'd like to discuss urinary incontinence, or UI. Simply put, urinary incontinence is defined as an involuntary loss of bladder control causing leaking of urine. So now that we know what we're looking for, what are the specific steps that a healthcare provider would take in assessment of a patient presenting with urinary incontinence? To start, is the type of urinary incontinence clear? For example, stress, urge, functional, or overflow. And we will discuss these UI types in more detail in a few minutes. You also want to know, has the patient had a previous continence assessment, and what information do you or they already know from that previous assessment if so? Ask about duration of symptoms. How long have they been experiencing this? When did it start? When did they notice the change in their bladder function? Determine frequency and severity of patient symptoms. Ask about volume of leakage. Determine if containment products are being used, and if so, what products. Ask about saturation level and product change frequency. Assess characteristics of the urine flow. What is the color? What is the turbidity? And is there blood present? Ask about aggravating or relieving factors of their incontinence. Ask about normal bowel routine, as constipation can impact urinary incontinence. And be sensitive to emotional impact. Create a safe space. Be considerate of past traumas and experiences the patient may have had that would make this type of assessment difficult. Is the patient avoiding social situations due to shame and embarrassment related to their incontinence? And of course, don't make assumptions about gender or sexuality based on whether the patient has male or female sex organs. Another important assessment consideration is the patient's individual surgical and obstetrical history. This is important information when assessing urinary incontinence and its underlying causes. For patients with male sex organs, the healthcare provider would ask if they have a condition affecting their prostate, for example, benign prostate hypertrophy or prostate cancer. You would want to know if they've had a previous surgery affecting their prostate, for example, a TURP. For patients with female sex organs, the healthcare provider would ask if they've had a previous gynecological surgery, for example, a hysterectomy. They would want to know about their obstetrical history, for example, number of births, perineal damage, or birth weight greater than 4 kilograms, or use of forceps, as all of these things can affect nerves, pelvic floor muscles, and continence. It's important to ask the patient if the patient is experiencing or has experienced menopause, as estrogen decreases impact pelvic floor muscles and urogenital tissues. So in the case of urinary incontinence, a bladder diary is one tool that geriatric assessors can use to further investigate and aid in their assessment. There are many different versions of this tool, and this one is going to be shared with you. A bladder diary is a detailed record of your fluid intake and urination habits, typically kept for 3 consecutive days. It's a simple but effective tool that helps patients and their healthcare providers better understand their bladder's behavior to diagnose and manage urinary issues like incontinence and overactive bladder. The patient will record data from the moment they wake up until they go to sleep, including any nighttime waking. They should pick a 3-day period that reflects their typical routine. This might include weekdays and a weekend day. Accurate data is crucial for proper diagnosis. Every event must be included, even small leaks, and measurements must be as consistent as possible. Habits should not be altered initially, and patients should try not to change their fluid intake or routine, as the goal is to capture their typical daily patterns. The diary should track key information in separate columns. So time. Patients should write down the specific time for every entry, including when they drink, urinate, or experience a leak. Drinks or fluid intake. So record the amount and type of every beverage consumed using a consistent unit of measurement. And remember to include all fluids, including soup or milk and cereal. Washroom trips and urine volume should also be included. So each urine should be collected in a measuring cup, and the exact volume should be written in the diary. And then urge level. So note the strength of any sudden, intense urge to urinate. Many diaries include a simple scale, such as 1 for weak or 5 for strong. If a urinary leak occurs, the incident should be recorded with details. For example, note the amount, such as a few drops, wet underwear or pad, or soaked clothing. And finally, cause. Record activities engaged in when the leak occurred, such as coughing, sneezing, laughing, or exercising. If containment products are being used, how many and how soaked they are should be documented. Some versions of the diary also include columns for tracking bowel movements, their consistency, and any pelvic pain experience, which can be relevant to bladder symptoms. So once further screening, such as a bladder diary, is completed, the specific type of UI can be more easily identified. This chart is from the Caregiving Strategies Bladder Health Handbook and can be found on the PGLL website. It offers lots of information about bladder health and incontinence management for patients and caregivers, and is going to be shared with you as well. So first, functional incontinence is described as the inability to get to the toilet in time due to physical or mental impairment, even though the urinary system is otherwise healthy. It's caused by factors that prevent or complicate timely toileting and not a direct problem with the bladder itself. An example of this would be impaired mobility or clothing that is difficult to get on or off. Next is transient or temporary incontinence, and it's defined as a leakage that is caused by a temporary condition that resolves once the underlying issue is treated. Causes of transient incontinence include urinary tract infections, as they can irritate the bladder, or constipation, as a full rectum can press on the bladder and overstimulate the nerves. Stress incontinence is known as an involuntary leakage of urine that occurs during activities that increase abdominal pressure. Stress incontinence is caused by weakened or damaged pelvic floor muscles or urethrosphincter. This is the most common type of incontinence in women, and common triggers are coughing, sneezing, laughing, exercising, or lifting heavy objects. An example of specific causes would be childbirth, as vaginal delivery can stretch and weaken the pelvic floor muscles and nerves, or in men, prostate surgery, as damage to the sphincter during a prostatectomy can lead to stress incontinence. Next is urge incontinence, and this is typically the type associated with overactive bladder. And it's defined as a sudden, intense, and uncontrollable urge to urinate that results in involuntary leakage by overactivity of the detrusor muscles in the bladder wall, which contract involuntarily. The urge can often be so strong that the patient can't make it to the toilet in time. Specific causes include neurological disorders like Parkinson's or multiple sclerosis, bladder irritants such as alcohol, caffeine, artificial sweeteners, and spicy foods. And it can also sometimes be idiopathic where there's no identifiable cause. Then there's overflow incontinence, which is described as frequent or constant dribbling of urine because the bladder doesn't empty completely or becomes overly full. It's caused by an obstruction or blockage in the urinary tract or a weakened bladder muscle that cannot contract properly to expel all the urine. Specific causes can include an enlarged prostate. This is common in men as it blocks the urethra. Pelvic organ prolapse in women as a prolapsed bladder can kink the urethra. Lastly, there's total incontinence, which is a complete loss of bladder control as a result of a neurological condition such as spinal cord damage or multiple sclerosis. Also important to touch on is nocturia. It's another common concern among older adults and an important part of a good continence assessment. Waking up once during the night to urinate can be considered within the normal range for both men and women, especially as people get older. However, waking up 2 or more times per night, the clinical definition of nocturia, is not considered a normal part or inevitable part of aging and should be evaluated by a doctor as it often points to an underlying medical condition. So how do we help our patients struggling with nocturia? I wanted to share with you the Tango. It's a self-administered validating screening tool for nocturia. The Tango helps to identify the potential causes of nocturia or frequent nighttime urination by screening for multiple comorbidities. It's divided into 4 domains. By assessing symptoms in these areas, the tool helps clinicians and patients understand factors contributing to the condition and guide treatment outcomes. The patient fills out the questionnaire themselves, typically by answering true or false to a series of statements. The questionnaire covers 4 main areas that can contribute to nocturia. Cardiometabolic, questions about heart and metabolic conditions such as diabetes, which can lead to increased urine production. Sleep, questions about sleep quality, sleep disordered breathing, like sleep apnea, or other causes of waking up during the night. Urinary tract, questions about common lower urinary tract symptoms that are relevant to nocturia, and well-being. Questions related to general health, including falls, daytime sleepiness, and loss of enthusiasm, which can be associated with nocturia. There is no specific scoring. The patient responses are used to identify which domain has the most symptoms. The domain with the most positive responses is considered the most likely contributor to their nocturia, guiding the clinician toward targeted evaluation and treatment. So now to apply what we have discussed related to bladder assessment and UI, I thought we would look at a case study. This is actually my grandfather, who does not have UI, but agreed to let me borrow his photo. For today's purposes, he does have UI, and he is Mr. C. So Mr. James C. is 89 years old and lives in a bungalow house with his spouse. His medical history includes hypertension and COPD. He is only on 2 medications, ramipril and a tiotropium inhaler. He is independent with his mobility. Mr. C reports urine leakage when he coughs or sneezes. Leakage occurs only during coughing and heavy lifting. He says, every time I have a coughing fit, I leak a little. It's embarrassing. He denies nocturia, denies urgency or frequency, and denies hematuria. He voids 5 to 6 times per day. He has a normal stream and has no sensation of incomplete emptying. He has normal gait and mobility. His abdomen is soft. He has no palpable bladder. His cough stress test was positive with a small leak observed. Pelvic floor muscle tone is found to be reduced if examined. Urinalysis is clear, and his post-void residual is 40 milliliters, which is within normal range. So Allison is going to launch a poll question, and the question is, what type of urinary incontinence does this patient most likely have? And I'll just give a minute or so for everybody to submit their answers. Should I end the poll, Allison?
Sure.
Yeah,
Yeah.
okay. It looks like everybody has answered.
We got lots of answers. Yes.
Yeah, okay. So the large majority was correct. It's stress incontinence. And the supporting clues for this conclusion are that the leakage was only with increased abdominal pressure, so coughing and lifting. He didn't have urgency or frequency or nocturia, and no rushing to the toilet. The positive cough stress test was indicative of stress incontinence as well, and the normal PVR indicated that there was no overflow component. Okay, so I can just exit out of that. There we go. Great. So now that we have covered bladder assessment, I'd like to proceed to bowel assessment, which also begins with a brief review of the gastrointestinal system. The gastrointestinal or GI system is a group of organs that work together to process the food we eat. The system is divided into two main parts, the GI tract and the accessory organs. For the purposes of bowel assessment, we will just cover the anatomy and function of the GI tract this morning. The GI tract is a long, hollow tube that runs from the mouth to the anus. Digestion begins in the mouth with chewing, also known as mechanical digestion, and saliva mixing with food to break down starches, also known as chemical digestion. Food is then pushed from the mouth into the pharynx or the throat during swallowing. Food then moves to the esophagus, a muscular tube that uses coordinated contractions called peristalsis to push food down into the stomach. The stomach is a J-shaped organ that mixes food with powerful digestive juices to break down proteins and turn the food into a thick liquid called chyme. The chyme moves from the stomach to the small intestine, which is the longest part of the tract, where most of the final digestion and absorption of nutrients occurs. It consists of three segments, the duodenum, the jejunum, and the ileum. From there, it moves to the large intestine, and this wider tube processes waste material. It absorbs water and electrolytes from the remaining indigestible food matter, which solidifies into stool. The rectum stores stool until an appropriate time and place to defecate, and the anus is the final opening where the stool is expelled from the body. So now that we have the GI anatomy and function fresh in our minds, I'd like to discuss fecal incontinence. Fecal incontinence is defined as the involuntary loss of control over bowel movements resulting in the accidental passing of stool or liquid stool or solid or liquid stool or mucus from the anus. So again, what are the specific steps a geriatric assessor would take in the assessment of a patient presenting with fecal incontinence? So first, you would determine the type of fecal incontinence. Is it urge, passive, or overflow? And again, I'll discuss these types further in a moment. Has there been a previous continence assessment by another healthcare provider that you can gather information from? Ask about onset and duration of patient symptoms. So when did it start and how long has it been going on? Determine frequency and severity of patient symptoms. Ask about volume of leakage. How much stool is there with each incontinence episode? Does the volume change at all? Determine which containment products are being used by the patient. Are they effective? And what is the change frequency? Assess feces characteristics using the Bristol stool chart, which we'll discuss in a moment. Is there blood? Has there been a recent change in consistency? Ask about aggravating or relieving factors. Are there triggers? Does anything alleviate the patient's symptoms? And again, always be sensitive to emotional impacts. Create a safe space and be considerate of past traumas and experiences the patient may have had that would make this type of assessment difficult or embarrassing. Determine a baseline. Ask about the patient's normal bowel routine, their bowel movement frequency and time of day, etc. So in the case of bowel assessment and fecal incontinence, tools such as the Bristol stool chart or a bowel diary can be used. The Bristol stool chart is a medical tool used to classify the consistency and form of human feces into 7 distinct categories. It provides a standardized way for both patients and healthcare providers to assess bowel health by visually comparing stool samples to the chart. The form of the stool depends on how long it has spent in the colon. The chart has 7 categories that describe a spectrum from severe constipation to severe diarrhea. Constipation is identified by types 1 and 2. Types 3 to 5 are considered normal, and diarrhea is identified by types 5 and 6. Healthcare providers use the chart as a clinical tool to help diagnose conditions such as irritable bowel syndrome or fecal incontinence and to monitor treatment effectiveness. It also improves communication between patients and doctors regarding bowel habits and allows individuals to self-monitor their digestive health. Consistent abnormal results, so stools outside of types 3 to 5, warrant consulting a healthcare provider. The other tool I wanted to discuss is a bowel diary. Again, there are many different versions. A bowel diary is typically kept for at least 7 days. Patients should choose a period that reflects their normal lifestyle, including weekends and weekdays, to get an accurate picture of their habits. For every bowel movement, the following details should be recorded. time and date, stool type, using the Bristol stool chart to classify, urgency, amount, for example, small, medium, or large, pain and straining, and any incontinence episodes. If you experience accidental bowel leakage, record the event and describe the amount, small, medium, or large, and what may have caused it, for example, cough or strong urge. Any food, drink, or medication should also be included, for example, laxatives or any antibiotic use. A comprehensive diary can help to reveal connections between your diet, activity, and bowel symptoms. Recording what you eat and drink throughout the day can help to identify trigger foods. Since the gut-brain connection is strong, tracking your emotional state can also be helpful in identifying correlations between stress and bowel habits. So with use of screening tools like the Bristol stool chart and a bowel diary, the type of fecal incontinence can be more easily determined. There are three main types of fecal incontinence: urge, passive, and overflow. These types are distinguished by both their symptoms and underlying causes. First, urge incontinence. This is the inability to hold a bowel movement despite a conscious, sudden, and strong urge to defecate. The person feels the need to go but cannot reach the toilet in time. It is typically associated with a weakened or damaged anal sphincter and pelvic floor muscles, which are not strong enough to hold back the stool. The urge may be difficult to control when the stool is loose due to diarrhea. Passive incontinence. This type involves accidental passage of stool or mucus without awareness or sensation of needing to defecate. It can range from a minor leak to complete loss of control. Passive incontinence often results from nerve damage that impairs the sensation of having a full rectum or dysfunction of the anal sphincters. This is common in individuals with neurological conditions such as multiple sclerosis, dementia, or spinal cord injuries. Overflow incontinence. This occurs when the rectum is impacted with a hard, dry mass of stool due to chronic constipation. Weaker, watery stool from higher up in the bowel leaks around the blockage and is unable to be held back, caused by fecal impaction, which is a complication of severe long-term constipation, often seen in elderly individuals or those with reduced physical activity. And then lastly, there's mixed incontinence. So some people experience a combination of types, and the underlying causes can also overlap. So how do we help patients that are experiencing fecal incontinence? The low FODMAP diet is one strategy. Developed in 2005 by Australian researchers at Monash University in Melbourne, it's a temporary diet limiting fermentable oligodimonosaccharides and polyols, or more simply put, short-chain carbohydrates. These carbs draw water into the gut and ferment, causing irritable bowel syndrome or fecal incontinence symptoms. Studies have shown that the low FODMAP diet helps approximately 70 to 75% of people with their bowel symptoms. There are three phases to the diet. First, elimination, where the patient strictly removes high FODMAP foods for 2 to 6 weeks. Then is reintroduction, where the patient tests specific FODMAP groups one by one to find personal triggers. And lastly is personalization, where the patient avoids only specific triggers while eating a diverse diet. One important caveat is to consult a dietitian before making this recommendation to a patient. The low FODMAP diet must be done under professional supervision to ensure nutrient needs are met and the reintroduction phase is managed correctly. It should be noted that it should not be long-term. The strict elimination phase is only short-term. A resource that outlines the specific foods that can be eaten and specific foods that should be avoided is going to be shared with you at the end of the presentation. So changing gears a bit, this is the last resource I wanted to share with you today to aid in your fulsome holistic continence assessment. It's the Ghent Global Incontinence Associated Dermatitis Categorization Tool, or the GLOBE IAD Categorization Tool. Incontinence-associated dermatitis is a type of skin damage caused by prolonged exposure to moisture from urine or feces. The GLOBE IAD tool provides a standardized way to describe and classify the severity of this condition, which helps ensure consistent diagnosis and documentation in clinical practice. The GLOBE IAD is an observational tool used by clinicians, not a self-assessment tool for patients. The process involves visually inspecting the affected skin areas and assigning a category based on the findings. The tool consists of two main categories, each with two subcategories. Category 1 is persistent redness or erythema. 1A is persistent redness without clinical signs of infection, and 1B is persistent redness with clinical signs of infection, such as white scaling or satellite lesions. Category 2 is skin loss. 2A is skin loss without clinical signs of infection, and 2B is skin loss with clinical signs of infection. Assessment findings can be communicated back to primary care to advocate for appropriate prescription ointments and incontinence products or containment products to promote healing. And a resource outlining this tool is going to be shared at the end of the presentation as well. So that concludes my presentation, the resources that I wanted to share with you today, and these are my references. And I think that there might be a few minutes for questions if anyone has any.
Wonderful, Ashton. I'm not seeing any questions yet, but I know we're going to pop that resource into the chat box with all of the incredible tools that have been suggested by Ashton. So um, I am going to press on if there are any questions. Oh, wait, we might have one question. I wonder what patients you might consider referring to a dietitian for consideration of a FODMAP diet.
Um, yeah, like so if they're experiencing fecal incontinence and it's a rather new thing, like not a chronic thing, you might want to try that out to see if that would be something that would help or resolve because like it said it does help 70 to 75% of people, so it would be worth a try if it was something that was new and wasn't chronic.
Excellent. Yeah, wonderful. Amazing. Okay, I'm going to press on. Thank you again. As I'd mentioned, the resources have been dropped into the chat box. Please have a look at them. They're incredible. Ashton, you are an incredible resource as well for North Simcoe Muskoka as you pursue your certification in continence nurse advisor. It's such an important role. So thank you so much.
Thank you.
Oh, I've got one question in the chat about pelvic floor assessment. Um, Sorry. As a clinician at an SGS center, do you often refer to pelvic floor physiotherapy for geriatric patients?
So they are a good resource, but the unfortunate thing is that they're not always covered. So it would depend on the whether the patient has insurance coverage for that or if they have, if they're able to pay for that themselves. But it is a very good resource if it's one that's
Absolutely.
available to them. Yeah.
Absolutely, yeah. Thanks for the question, Nadine. Yes, wonderful. All right, if you don't mind just popping to the next
Yeah.
slide, I want to highlight for folks, and that's in the document that we've added as well. We've got this is our final practice short for 2025, and starting January 9th, we have Jenna Wickens coming to speak to us around ageism. So we're excited about that as well. You can use your phone to scan here, or there will be some follow-up emails as well to everybody. So next slide. I always like to put a little plug in for some of the education that's happening with NSMSGS. So please have a look at our website, nsmsgs.ca. Kim Simpson has also added something into the chat box around the PGLO common orientation information. So there's a great opportunity there for you as well. Again, Ashton, thank you. Really well done. Huge congrats. So thank you,
Thank
everyone, and
you.
happy holidays.